Alrighty, let's see here. Let's see. How we doing? I think we're doing pretty good. Let's take a look. All right. Let me just start sharing this everywhere and then we will get going, okay? Da, 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 da. Da, 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 da. What are we doing here? Let's go home. All right. Let's see how this is going. Let's take a look. Do, do, do. Da, 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 da. Da, 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 da. Always fun. Here we go. There we go. We are all posted. I think we are live. I think people can see me. I can see me. I think that's good. I think it's all good. I think it's time to get going. I think it is time. Thank goodness. Okie dokie. Alrighty. Well, welcome everybody. I'm checking the chats. We're here. We're live. This is UnShrink Me. Welcome to UnShrink Me. We have a number of interesting mental health related topics today. I am Dr. Patrick Lockwood, but for the purposes of this discussion, please don't sue me. I am just Patrick Lockwood. And I'm here to talk about mental health, therapy, psychiatry, and the other things related to the professional world of clinical psychology and trying to help people with their mental health. The spirit of this podcast is somewhat satirical, somewhat critical, and always in the service of the people who are trying to be helped. Because, as many of you have heard me say before, my main problem is not with the patients or anything of that nature. My main concern is actually with the profession. I believe there are many aspects of the profession that are going well. Also, I believe there are many aspects of the profession that need lots and lots of support. There's a lot of burnout. There's a lot of mental unhealth in the profession. There are lots of greed and systemic financial issues in the profession. There are unprofessional and ethical issues in the profession. And there's just a lot of hurt people trying to help people, which is, I'm clearly not perfect. I made mistakes this week that are, embarrassing, frankly. And so, I'm also a regular person, as we all are, who are trying to help people. So nothing I say here is from the perspective of I am better than my colleagues or anything like that. It is all in the spirit of let's have an honest conversation, and hopefully I'm funny sometimes, talking about these various problems that our profession can handle better and that we can do a better job of maybe managing so that we can help people better. That's my goal. And as always, not technically formally sponsored by Celsius. Not, but it's so amazing. Thank you. It's good stuff. So let's go over the topics. So we've got some psychiatry stuff to talk about, some resilience stuff to talk about, and some therapy stuff to talk about as well. So let me see where to start. Okay, here we go. So something that I think is not necessarily good for the mental health of young men, young boys, is there's this article in the Daily Mail. Again, it's the Daily Mail, so I have no clue what's true, but it was published on about 3/29 last week. This says schools are going to start giving boys anti-misogyny lessons to stop toxic masculinity in the wake of this Netflix special or TV show called Adolescence. Now, in full transparency, I've never seen this TV show. I'm just going to tweet about this real quick. So, you know, not having ever seen the show, knowing nothing about the show, in the spirit of like trying to be reasonable, I have no clue what the messages are. In the culture war sense, it's always the case that whenever, there's some messaging to young men to make them not misogynists, it seems similar to the kind of APA message to men and young boys to help them not be misogynists. And I did a video on that years ago, which basically, is very simple. There's a way to talk to young men, adolescents in particular, that encourages them to be a better version of themselves, that allows them to help or to be part of like a healthy masculinity. I see there's a question here. Deidre Bartlett. Is that just in California or nationwide? I don't know what your question is in reference to. Is it in reference to the post I'm talking about? I'm talking about an article in, I think, a UK, United Kingdom paper called the Daily Mail. And I think that shows it's a Netflix show that's everywhere. It's called Adolescence. But I think they're going to start talking about it in schools with young boys in the UK to help them be less misogynistic. And I have no clue if that's going to ever happen here, but I think in the UK they're trying to help young men be less misogynistic. And, again, I've never seen the show. I have no clue what the show is like. And so my hope is that the show is trying to talk about like healthy masculinity. Or if it's not, it's trying to send the message that men are bad or boys are bad. I hope it's not that kind of black and white thinking approach. I'd have to actually honestly watch the show to have an informed opinion. What I would say is there's a way to talk to young men. I've worked with adolescents for years in my life. I've worked with, I've worked with young men between the ages of like 15 and early 30s for most of my career professionally. And I, as a young dude, had these conversations with my dad and other mentors. And what I can tell you is that it's actually not that complicated to talk to young men and help them become better versions of themselves. It's not that complicated to help them become a better version of masculine that's not, I don't know, something woke or something idealistic. Like, I think a lot of this idealistic thinking about how men should be and how women should be, and gays and straights, is just silly, because there's nothing wrong with having ideals, but like pretending that there's some super virtuous, super moral way of being that everyone's going to function as, especially given their gender and sex and all this stuff, is silly. If you want to have a healthy conversation with young men, it's actually not that complicated, and I've done this both professionally and personally for many years in my life. Many people, especially men, want to feel like they're accomplishing things. And they want to feel important, and they want to feel, in many cases, powerful. Now, some people are less driven by power. That has something to do with culture or personality or testosterone or whatever. But most people want to feel competent and important and valuable. And young men typically are socialized to do it through providing, achieving, excelling, using their body, sports, all sorts of things like that. None of which is inherently pathological or bad. And so what I'm worried about with this TV show and with the UK in general is trying to shame people for, wanting to excel in sports or excel in business or their career, or maybe be a masculine stereotype of sorts. If you want to be jacked and huge in the gym, awesome. Maybe don't do steroids because that's bad for your heart, etc. Again, I'm not a physician, so don't sue me, but I'm pretty sure steroids are bad for you. They're Schedule III drugs, for the DEA. But it's okay if you're a young man and you want to be something. It's okay if you want to achieve. It's okay if you want to dominate. If you want to be like the best football player, basketball player. If you want to be a CEO, if you want to be a tech nerd, if you want to be a psychologist like me or my friends. If you want to overachieve at something, that's super awesome. And it's awesome because whenever we can do something to give back to the world and use our gifts to help people, that's awesome to me. Which to me is in many ways no different than women, but women have different psychological, biological, and sociocultural differences that allow them to function in society in a way that allows them to live out their life meaning and purpose differently. So men and women are different, but in the ways in which men and young boys are different, I just want to encourage them to, treat women with respect. If you're into women, etc., don't abuse them, don't rape them. Maybe ask for consent. Seems like a good idea. Like, maybe be reasonable. Maybe learn how to be a person of integrity. Maybe learn how to use your principles and your skills and your gifts to help people and be of service and to lead if you're a leader type of person, and to contribute and to set the example if you're capable of that. Sometimes we're not. Like this week I failed, but I'm going to pick it back up and do better next week, And to me, that's part of being a leader, is you figure it out and you do better, And so my hope is that young men and young boys get the positive messaging around masculinity, which is you are capable and you are valuable and you are worthy and you have different traits and skills and strengths and gifts that allow you to function well as a valuable man in society, to your family, to your friends, to your city, to potential romantic partners. Not you're evil and vicious because maybe you're on average more impulsive, or you're evil and vicious because you're more testosterone fueled in some ways, or stupid, or whatever it is. Sometimes young boys in particular need to be stupid and be rough around the edges to figure out how to become more mature, integrated men, right? So if we're going to rob young boys of the opportunity to learn how to be more mature by making mistakes and by learning to deal with their impulses better and learning to deal with their personality differences better and their ego and all these things, then you're going to hurt the next generation of young men and boys. So I want to help them. I want us all to help them by accepting them for what they are and encouraging them to do better, but not shaming them and scolding them for their various differences, interests, and things like that. Let them be stupid. Sometimes that's how we learn, is by being stupid. That was my experience this week. And I'm not all that young anymore, unfortunately. So that's all I'll say about that. Next up. All right. The next person on the list. Thank you for coming out to chat, Deidre. And if you have questions, feel free to ask. The next person on my list is a guy named Justin Garson. Or Garson. I'm not sure how to say your last name, Justin, so I apologize. So Justin put out a post 4 days ago. And I've spoken about him before. So this is in good faith. And I'm just going to tweet about it real quick. So his post 4 days ago, and his handle, if you don't know, or if you don't remember from other episodes, is at Justin_Garson, Garson. So his post was, it's dehumanizing to use the language of medicine to frame mental health struggles. For instance, symptom, in quotes, disorder, in quotes, diagnosis, in quotes. These labels strip us of agency and context, replacing the humanistic language of problem, crisis, and reaction. So here's how I interpret this, and if I'm interpreting this wrong, Justin, you're welcome to correct me or tweet at me or whatever it is, and I would love to have a more full conversation. So he is saying that symptom is synonymous with problem, disorder is synonymous with crisis, and diagnosis is synonymous with reaction, I think, because it's 3 things in a row in quotes and then another 3 things in a row in quotes. So I'm going to interpret it that way. If I'm wrong, let me know, Justin, because I'd like to actually understand you correctly if I'm misunderstanding you. So also, just for context purposes, since he mentioned context in his post, my understanding of Justin's experience is he was harmed by the professional mental health industry. I don't know if it was a therapist or psychiatrist or both or whatever. And so he's come to a new place where he's very critical of the industry and maybe part of the reason he's saying these things is because these are things that happened to him. So before I get to the specifics of, is symptom the same thing as problem, disorder as crisis, and diagnosis the same thing as reaction? I would like to say that it's absolutely true that professional mental health services and the providers in the system absolutely make mistakes and will over-pathologize, overreact, or underreact, or misdiagnose, or read into things. It's not uncommon at all because, again, every person in the profession is a human being until AI replaces us. And, if AI does replace us, God bless. You know what I mean? I'll just do this all day. But, I think, notwithstanding the fact that, the human beings who are in this profession are flawed, sometimes burnt out, sometimes not very mentally well themselves, sometimes mentally ill, or struggling with a substance use disorder, etc. I can grant that a lot of over-pathologizing happens. I can grant that over-treatment happens with therapy and medications and structure and all these things. And then I also get stuck because I have various voices in my head. I promise I'm not hearing things. I'm not hallucinating, but culturally, there's all these voices in my brain. Like Alan Francis, who is a former DSM committee member, psychiatrist, who says, as much as labels suck and diagnoses suck because they over-pathologize things, they're still necessary because they help us deliver treatment as like a communication and way of understanding difficulties. So I have many voices like that, which are relatively reasonable in my head. My clinical experience and my professional experience is similar, which is I've met so many people in my career so far in the last 15 years, before I was licensed and since I've been licensed, that were incorrectly diagnosed or over-treated, because there is definitely such a thing, both with therapy and with medications. He's right. Justin's correct in his original post. A lot of people, when they are being treated or diagnosed or pathologized, there's a world of context that is missing from understanding who that person actually is. So I definitely side with him in that way. In fact, one of my favorite psychotherapy approaches is called acceptance and commitment therapy, which is very focused on creating more context. And another one of my favorites is called IPT. Excuse me. And so these various types of interventions I'm appreciative of and try to use in my clinical practice, or at least integrate to some degree, because I'm not formally trained in ACT, for instance. I believe that context is extremely important, and one of the reasons why people suffer, actually, whether they have a diagnosed mental illness or not, is because they're hyper-focused and rigidly focused on one perspective of their experience. So they're stuck in a rigid thought pattern. That rigid thought pattern about themselves, for instance, needs more context, right? The example I literally always give in my professional life when I'm a professor to students, when I'm teaching about psychopathology, or to patients and families when I do different types of clinical work, is this. A lot of what happens that makes us very ill, and at least struggling even if we're not diagnosably ill, is there's some kind of mismatch between our thought process and the full picture of reality, right? There's a discrepancy between these two things, and it causes us ambivalence and stress. So imagine this. Imagine there was a Broadway play, right? So many of you have probably seen various Broadway plays. There's a number of classic ones like Streetcar Named Desire and Cats and The Phantom of the Opera and Les Mis and all these things. And so all of these plays basically are broken down into three components if you want to break them all down. So a play or a musical has three basic components to it. It has the actors, performers. It has the orchestra and the band. And then it has the backdrop or the set and the scenery, right? And so for a lot of people with various mental health issues, whether they're diagnosable or not, part of their problem is that they're missing the greater context. So like maybe they're super engaged in the actors and the music, but they don't really understand the set that they find themselves acting in, for instance. Right? And then for other types of people who are struggling, there's a giant disconnect between one of these three pieces and the other two pieces. So one way I've described various types of illnesses before, like psychotic disorders, and again, this is just a metaphor that might help people understand it better, not like a formal professional understanding of what it is. But for a lot of people experiencing hallucinations, they're experiencing a very stressful internal world. Because just imagine, just to mention three of the Broadway musicals I referenced earlier. So let's go with Cats, which is literally a musical about cats. And then let's go with The Phantom of the Opera, which is about some guy in the Paris Opera House who's killing people and in love with an opera singer. And then let's go with Streetcar Named Desire, which is about gangs and early Americana and stuff like that. So different cultures, time periods, and all these things. So imagine how confusing it would be as an audience member if you sat down to watch Cats, which, I've never seen, so I don't have any snippy, funny comments to say about it, other than it's been made fun of a lot. And I think the newer version of it was kind of terrible, but I've never seen it, so I can't really say. But imagine you were there to see Cats, a musical about cats and blah, 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 and all that. And then imagine that once you sat down and the musical started, you started to hear the music for The Phantom of the Opera, which is very jarring, by the way. So you're sitting down to watch Cats, and then you hear this jarring Phantom of the Opera music. And then when the curtain lifts, you see this background for Streetcar Named Desire. You see this like 1930s Americana background. So it's the music of The Phantom of the Opera, the actors for Cats, and it's the backdrop for Streetcar Named Desire. That's a very weird, jarring experience because those three things don't make any sense together. And so the truth of the matter is, that's your current reality. You're watching three things that should supposedly make sense together, make zero sense together. And it's 100% real to you that you're watching one play with completely different music and completely different actors other than what you expected, with a backdrop that makes no sense. And that's what it's often like for folks who are experiencing hallucinations and delusions. They are literally experiencing a reality in a way that's not concordant. They're experiencing things that are real to them that make literally no sense. And so there's a real context there for many of these mental health conditions and symptoms, which is the person is perfectly smart and perceptive, but the parts of their brain responsible for making sense of things are pulling up and confabulating information in a way that other people are not. But the bigger context around that particular example is, if you actually look at the neuroscience of, for instance, psychotic disorders, and you actually understand how perception actually happens, the fact of the matter is every human being is projecting and confabulating. Everybody is literally making up reality in their head. And so literally, people with hallucinations are, in some technical sense, no different than the normal sane person who doesn't have hallucinations as a symptom, because literally everyone is creating reality in this moment, right? So if you read neuroscience researchers like Lisa Feldman Barrett, she calls a lot of what we're doing predicting, right, with our brain. And if you look at Carl Friston's work and a bunch of other brilliant neuroscientists, it's absolutely the case that our brain's not necessarily hallucinating per se, but it's confabulating. It's creating reality based upon our prior memories and experiences. So we're not sensing something for real in like a raw sense. We're actually creating what we're sensing in all five of our senses based upon our memory and our prior experiences, which is absolutely wild. And so from that contextual perspective, persons struggling with hallucinations aren't all that different in some ways than the average person walking around who's not experiencing a hallucination. It's just that our confabulation machine as people not with hallucinations is more geared to the common sense shared reality that everyone else is experiencing compared to the person with hallucinations who's confabulating wildly in ways that aren't very rigidly predictive of what is considered reality. So that's a long technical way of saying we're all kind of hallucinating because we're all creating our reality in our minds with our memory. But it's just people who are hallucinating are creating a reality that's much more discordant with everything else that everyone else sees and experiences on a regular basis. So all that's to say, to Justin's point, I'm with you, my friend. I'm totally 100% on board with the fact that context matters and over-pathologizing happens. Here's where I get stuck, Justin. And just to make sure and refresh for anyone who's like catching this later, here's the tweet again. It's dehumanizing to use the language of medicine to frame mental health struggles. Symptom, disorder, and diagnosis in quotes. These words strip us of agency and context, replacing the humanistic language of problem, crisis, and reaction. Here's what I'll tell you, Justin. To me, it is 100% the case, having worked with folks with very severe mental illnesses for a long time, that there is no such thing, in my experience, as someone who can control their hallucination. Now, maybe there are other people out there that I have not met who have been able to control their hallucinations. My experience has been when you're struggling with very serious hallucinations, you do not have the ability to wrangle them while you're actively struggling with them. And there's kind of a correlational experience. The more overwhelmed you are emotionally or stressed out, the more intense your hallucinations become and they're harder to manage. So to me, I see that there's absolutely a necessity, Justin, to medicalize many different types of symptoms, despite everything I said about context in the brain and those 3 musicals and how everyone's confabulating and mildly hallucinating. I agree with everything I said, and also I agree that it's literally the case that some things are so severe, the symptoms are so intense and beyond the person's conscious control, and they're so impairing, as in they can't maintain their activities of daily living, they can't pay for things, they can't work a job, they can't do things that take care of their basic necessities. They're so impaired that this should be an illness that should be treated and given lots of support and understanding. So I think the problem with like demedicalizing many different types of conditions is if you demedicalize them, then a lot of important treatment options are now off the table. And so I'm very concerned about taking people with severe illnesses and treating them like people who are the worried well, right? I've talked about this on my podcasts before. There are people who are the worried well, who come to therapy all the time. There are people who have basically functional lives. They have mild distress, like mild anxiety and mild depression. And I'm not saying they're not suffering. They're probably suffering a whole lot and they feel bad. However, they're functional and they're actually capable of thriving despite their difficulties and their suffering. To me, that's closer to the worried well than what I was describing earlier with severe hallucinations, severe grandiosity, impulsivity seen with bipolar 1 disorder, and things like that. Those are very obvious circumstances where if you can't functionally manage yourself and negotiate in good faith with other people, because you are quite literally mentally ill, then I think that mental health crisis, as you described it, Justin, is actually a disorder, because disorder implies something that's treatable. And many of these things are actually treatable, if not manageable. So I never want to strip anybody of their agency and their context, Justin. I think the more we see the context of people, like in acceptance and commitment therapy, the healthier people become and the more agency they feel like they have. So I'm in agreement about that. What I'm not in agreement about is demedicalizing things when if someone is actively hallucinating, I've seen so many people helped by drugs like Zyprexa when they're actively hallucinating that I would never want to discourage people from being provided those drugs if they're actively hallucinating and at risk to being homeless, at risk to being imprisoned for no good reason because they're mentally ill. Like, I'd rather them not go to jail if they're on the correct meds, because sometimes meds keep us from being impulsive in a very dangerous way. Society is not built for the mentally ill, unfortunately. There's a reason so many people end up in jail with a mental illness, right? Just the pure number of folks with diagnosable PTSD, personality disorders, mood disorders, substance use disorders, those are all mental illnesses. And so many people in jail have those mental illnesses, which means society is not built for the mentally ill. Society is built for people who are willing to comply. And understandably, folks with various types of mental illnesses are probably not as readily interested in complying or as capable in some instances because maybe they are so mentally ill they can't, right? If you're actively hallucinating, you can't talk in good faith to cops when they're arresting you, for instance, in many cases. So I find myself very torn, Justin. You make a good point in the sense that we should not dehumanize people. We should see people as complicated, nuanced, contextual beings, dynamic beings, changing beings. And some people are seriously mentally ill, and they absolutely have to be on meds in order to be, unfortunately, functional. It's a sad thing to say. I don't like it, but I've seen it in my career plenty of times. I would never just want to let them roam like free range mentally ill. Like, that makes zero sense to me. If you're that severely impaired, it's not a good idea. And so I don't think those three things are synonymous. I think that, making those three things synonymous is not a very reasonable thing to do, Justin. And maybe we should talk it out. Maybe we can. Oh, that's so good. Okay. Tastes good. There's this person I've seen a few times on Twitter. His name is Dr. Joseph, or it's his handle. His handle is at Taper, T-A-P-E-R, Clinic. His post from 4 days ago was, cannabis today is not the same as it was 20 years ago. He goes on to say, THC levels have skyrocketed, and with it, I'm just going to post this. And with it, more people are experiencing cannabis-induced psychosis, sometimes leading to long-term psychiatric diagnoses like schizophrenia and bipolar disorder, a thread. And so I'm not going to go through the entire thread because there are many posts, but just know that in his post he discusses the fact that by history, by the data we have, the conversion rate to a full-blown psychosis or bipolar disorder has gone up precipitously in the past few years. For instance, he cites a Danish study where 7,000 people with substance-induced psychosis were followed, and about 47% of those people went on to develop either schizophrenia or bipolar. And there's a number of studies coming out like that for the last couple of years showing that. And so here's what I will say. Here's something that is a problem, and he talks about this in the thread. One of the main problems with this is, when people develop a substance-induced psychosis, like meth causes psychosis or weed can cause psychosis if it's high potency in particular, a lot of people get put on meds to manage their hallucinations and delusions, like I said earlier. And most meds are good for more hallucinations than delusions. But mostly, it's really important that when people become medicalized because of their substance-induced psychosis, that's going to have consequences. And so it's really important for people to understand that it's very risky when you do these drugs and you develop these drug-induced psychotic symptoms. Because, the cannabis of decades ago, when the Gen Xers and the Boomers were really worried about weed and smoking a bunch of weed, it was 4 to 5% THC. Back in the 70s. The weed that exists now is like 20% THC, 30% THC, and higher percent content, which means it's extremely potent. It's an order of magnitude more potent in some cases. And there's like wax and dabs and butter, BUDDER, and shatter, and all these different types of cannabis products and THC products, these resin products that are super high potency, upwards of 90% THC in some rare cases. And that's absurd. That will make you at least have temporary paranoia and psychosis. And in some cases, it can really hurt you and cause the onset of a very serious mental illness, like we were just talking about. And so, although I'm not anti-weed, I'm not anti any drug, even though I've worked with people with serious substance use disorders for years, concurrent with their other mental health diagnoses like bipolar and depression and PTSD and things like that. I will definitely tell you that, I've seen more and more young people who smoked way too much weed for way too long, despite having either negative symptoms of schizophrenia or positive symptoms like hallucinations and delusions. And they just went over a tipping point that nobody can see. Nobody knows biologically what the tipping point is. Nobody can tell you how long you can get away with smoking high potency THC. Nobody can tell you how much meth you can do before your temporary psychosis becomes a full-blown psychosis. I did an initial screening phone call like a month ago with a perfectly bright young man, and he was part of the chemsex world, which is where young gay men have lots of sex, I would say promiscuous sex, even though I don't want to use shaming words, with like serious drug use, like drugs like GHB, which is the date rape drug, and Xanax and Molly and poppers and alcohol and meth, right? And this young man was telling me that he was very worried that his temporary psychotic experiences were going to become permanent, and I validated that worry because it can, if you do enough meth, it can, but nobody can tell you. There's no regression model that tells you if you do meth for this long in this dose, over this period of time and this intensity, it's going to predict long-term psychosis. We don't have that data because we just don't have good data. We have some good data, but we don't have that kind of quality data, So it'd be great if we could create that model, but we don't have it. And so it's literally a gamble, right? Because nobody knows how their brain is built. Probably one of the greatest secrets or one of the greatest, most important, in my opinion. I will say this is my personal opinion, not even my professional opinion. One thing that always bothers me that people in my profession do is they pretend that they understand how the brain actually works. I always think this is such a magician's act. Whether psychiatrists do it or psychologists or other therapists, I don't even care. Actually, quite literally nobody knows how their brain is built. Not metaphorically, literally. Very few people have experienced X-ray crystallography of every one of their neurons. That's impossible. There's just billions of them. You couldn't. It would cost $1 billion to fully map out what your brain looks like at this point, using X-ray crystallography and PET scans and all these things. And you'd die from all the radioactive dyes and stuff. It just wouldn't, you couldn't. So literally nobody knows how their brains are built. Nobody. It's impossible. And so because it's impossible to know how you're built, all you can do is pay attention to these vague signs and symptoms that maybe you're pushing on a sensitivity and a vulnerability in your brain. So if you're smoking a bunch of weed and you're noticing that your anxiety is getting worse, that's called anxiety rebound. Or you're noticing that you're becoming a little more paranoid than you normally were once upon a time when you smoked weed, that's a very crystal clear sign that your cannabis use is worsening your anxiety and putting you at risk of developing serious issues. Obviously. So something is up about your brain. Maybe don't do that drug, at least in that way, right? This is not medical advice, but if you're starting to become more anxious as a result of your weed, or you're starting to become more paranoid, maybe something is wrong. Seems pretty common sense. Maybe don't do that. I don't know. This is not medical advice. It just seems like a pretty obvious thing to say. So that's the level of sophistication we're currently at with regard to the neuroscience of it all. We don't literally know what that tipping point is for any person, even with a family history of psychosis or a family history of substance use disorder. Nobody can create the predictive regression model to tell you specifically, you, sir, are at X% risk because you've done weed for this long and used these other drugs and you have these pre-existing family illness history and diabetes and depression and psychosis. Like, nobody knows. Nobody knows. All we can do is speak at the widest, biggest umbrella level of abstraction. We can speak from 30,000 feet looking down. If you generally do too much weed, bad things are going to happen. If you generally use meth for a long time, bad things are going to happen. Which is kind of like saying the sky is blue. But weed used to be no big deal in terms of your brain, comparatively speaking, because it was so low potency, comparatively speaking. Back when it was 5% THC and it wasn't specifically cultivated, it was no big deal because it wasn't going to cause such intense psychological experiences that it would typically activate underlying predispositions, stress-based predispositions, so on and so forth. Now, there was a study that came out, what was it, a couple of weeks ago that said that long-term use of especially higher potency THC did increase the risk of heart issues, I think. I'll double check that and get back to you all next week, but that was concerning to me. So maybe, just maybe, it's more important to be even more reasonable and responsible with your THC use if you smoke weed, take edibles, whatever it is. Because it's riskier than it was decades ago. You know, it's not to be dramatic, it seems like the THC of today, the weed that people consume today, the cannabis, the edibles, it's much more potent in a way that people don't understand. So like a somewhat reasonable comparison is like, it's the difference between cocaine and meth. Meth has like a 12-hour half-life, whereas like cocaine has like an hour, 3-hour kind of experience. So like, if you think you're having a coke experience, we're going to come down and crash and feel horrible for a day. Whereas if you're high in meth, you're going to be on meth all night and then up all night. Like, it's very different. It's a very different drug now. Weed's very different now. And so you have to have a better relationship with it, I think. So buyer beware. If you consume cannabis, be very careful. Because you just don't know how your brain's built. Like, none of us do. None of us, just to say this extremely clearly, nobody knows how their brain is built. Not the smartest people, not the dumbest people. Not Elon Musk. Nobody knows. Nobody has had the billions of dollars worth of scanning, x-ray, crystallography, etc. it would take to actually literally know how every neuron is built. Also, if you didn't know this, your brain changes its chemistry, its structure over time based upon your experience. And so it might be built a certain type of way at 16. And then during puberty, as your brain changes over and over again, it'd be different at 25 based upon experience and development and all these things. It will change over the course of your life. So pay attention to the vague symptoms and signs and take them seriously. All right, next up, my good friend. He's not technically a friend, but I think he's great. Jonathan Shedler. His handle is at Jonathan Shedler, Shedler. Posted, let me see what this is from. An article by Aaron Dolan that was published on March 30th, 2025. I'm going to tweet about it real quick, just so everyone's aware. There's like a time and a date stamp. So there's a paper that came out in Nature that showed that essentially when people are online self-reporting and self-diagnosing with autism spectrum issues, it doesn't line up with actual clinical diagnoses of autism spectrum disorder. So the short story is, please don't self-diagnose, because literally you have all sorts of biases, which I would say for anything in mental health and psychiatry. Like, none of us are perfectly self-aware, myself included, obviously, and we can't self-diagnose. We can be aware of the things we feel like we're experiencing, but we're very biased. We have defense mechanisms and all these things. Excuse me. So, generally, don't self-diagnose. It's just not worth it. If you really think something seriously pathological is happening inside of you, etc., go see a professional. Go become, a patient even temporarily and just get assessed in a couple of evaluation sessions. It's worth the expense because I think sometimes you're just the worried well. Sometimes you have some serious stress right now or struggles, but it's not an actual diagnosis. And sometimes you actually have had a diagnosis for a long time, but just weren't aware of it. So both possibilities are true. Self-diagnosing is bad because we have biases that make us look good, look bad for whatever reason we want, which we're not perfectly aware of because no one's perfectly aware. So, short story, please don't self-diagnose. Even if you think you're neurodivergent or autistic or something of that nature, don't do it. It's not worth it. I promise. All right, one of my favorite posters. I'm just going to tweet about it real quick. One of my favorite Twitter friends, ex-friends, is No BS Therapist. Her handle is @tweetatherapist. This was 2 days ago. So 2 days ago, she's quote tweeting somebody who said, his name is Brooklyn Frank. So his post was, New York City downtown black culture. Sounds like therapists here are actually using their clients for social lives, or at least trying to be actively involved in their social circles. Something is very wrong with their entire practice of psychiatry, from what I can tell. So I'll respond to that, but then here's what she said. Has anyone heard about this, is what she said 2 days ago. Therapists inviting clients to concerts and weddings. Please speak up if so. And a number of people actually responded, myself included. Here's what I will say. Psychologists, psychiatrists, therapists of all kinds, mental health professionals of all kinds have an ethics code. Our ethics code is extremely clear about these things. So, because I'm a psychologist, unfortunately, my ethics code is from the American Psychological Association, about which I have many frustrations and gripes. And in the ethics code, we have these general principles like beneficence and non-malfeasance, which is our job is to help people and not hurt them. And fidelity and responsibility, which is we are responsible to the profession to help those people and do our best to do the right thing. Integrity, we deliver on what we're going to say. We deliver justice. We help people who are marginalized. Respect for, and principle E, respect for rights and dignity. We do not shame, dehumanize, or destroy, hurt people, etc. Section 3 of our ethics code is on so-called human relationships. And section 3.05 of the American Psychological Association's ethics code talks about so-called multiple relationships, which speaks to this particular tweet. So here's what I would say. I don't know what's going on in New York City, if it's like just some psychiatrist or therapist or psychologist who are doing this, or if it's like a cultural norm where you go hang out with people who you also happen to be treating. I don't know. I don't know what the truth is because it's all hearsay and it's like one example of one tweet on Twitter. So here's what the American Psychological Association's ethics code actually says about multiple relationships and the problems inherent with them and what you shouldn't be doing as a professional. So a multiple relationship occurs when a psychologist is in a professional role, like professionally you've signed a consent form where you're actually treating the person with a person, and number one, at the same time is in another role with the same person, and number two, at the same time is in a relationship with the person closely associated with your patient or whatever, or three, promises to enter into another relationship in the future with the patient, or a person closely associated with them. So there's three types of ways you can be in a multiple relationship as a professional. You can either, number one, be in the professional psychologist role and another type of role with them, like business partner, friend, lover, whatever it is. Or two, you can be in a professional relationship with the person and then their friend, their family member, their partner, their spouse. You can be in a relationship with that other person associated to the patient. Or three, you can promise to be in a future other multiple relationship with the patient. A psychologist, the ethics code goes on, the psychologist refrains from entering into a multiple relationship if the multiple relationship could, favorite word of the APA, reasonably be expected to impair the psychologist's objectivity, competence, or effectiveness in performing his or her functions as a psychologist, or otherwise risks exploitation or harm to the person with whom the professional relationship exists. So you are not supposed to be in a multiple relationship experience with your client, your patient, if it's either going to A, impair your objectivity, competence, or effectiveness, or B, otherwise exploit or harm the patient, etc. Multiple relationships that would not reasonably be expected to cause impairment or risk exploitation or harm are not unethical. So going back to the tweet, based upon what the ethics code actually says, it sounds like the therapist here are actually using their clients for social lives, or at least trying to be actively involved in their social circles. So I don't know what it means to be actively involved in their social circles. So like here where I am in Southern California, I will occasionally run into either a patient or one of their loved ones, etc., out in the world, like at the gym that I go to, or at the store, or at a coffee shop. And so, the general rule of thumb in the business is you never make first acknowledgement or contact. If they acknowledge you, that's different. But if you don't acknowledge them first, like they come to you and, otherwise you don't say anything because you want to keep their confidentiality, protect their privilege, right? So it's not weird to see people out and about. Many of us live in small communities where you can't help but see people at church or see people at the store, at the gym, or whatever it is. So that's one thing. But then it's another thing to be actively seeking out a multiple relationship with somebody where it's like a friendship, a business partnership, a romantic relationship, or just like a purely hedonistic sexual relationship. Like any of those four things would, I think, generally be frowned on, if not legitimately unethical. And so if this is a norm in New York City, that would be surprising. I doubt that for some reason. Maybe there's certain sub-communities, subcultures, or maybe it's more expectable or understandable. I don't know. What I would also say is one of the hardest parts about being a professional is knowing what is culturally and socially expectable out in public, because we operate in this very weird double life kind of thing where it's like I'm a professional from 9 to 5 or 8 to 6 or whatever it is, but then when I go live my personal life in the evenings or the mornings or lunch or on the weekends, I have to all of a sudden not be this professional who knows all this stuff and has all this private information. It's kind of like being an FBI agent or something. Not that it's the same, but it's a similar kind of you're expected to be a regular person and also this super secret professional. So it's weird. And so I can understand how some people would struggle to be perfectly neutral or to not be unintentionally in a multiple relationship by accident or just because you happen to live in a tight-knit community. That wouldn't be too weird to me. But actively seeking it out, what I worry about there is obviously the APA ethics code problem of like, creating an extra bias that could exploit or harm people or create false expectations of what a therapist is supposed to be. But also, like, what's your real motivation for going to be friends with your patients? Like, it sounds like the clinician in that case might have an unmet need that they could probably get met in better ways, which means they're probably not the most objective. Because, like, it's not weird for psychiatrists, psychologists, professionals of all kinds to have their own personal issues and unmet needs. It's just kind of well known that from an ethical perspective, you don't get your unmet needs met with your patients, right? So if you feel lonely in your personal life as a professional because like you're a workaholic and you have no friends, you don't try to become friends with your patients. You might become friends with your colleagues, or you might be, go to therapy or something, but like you don't typically get that unmet need met with your patients. And so like I can definitely think of a couple of times in my career so far where after a patient has finished working with me, a couple of people have wanted to check in a couple of times or say hello or have phone calls. And that's all pretty typical stuff. But I've never pursued a friendship with any of my former patients, let alone my current patients. And thank God most of them don't want that, But like, it would be weird because that means that I'd be in a completely different relationship with them. And so I think it's really important, if that is true, that whoever is engaging this behavior, whether it's here in LA or over there in New York, that they really figure out the difference between like being part of a close-knit community maybe and having these unintentional or difficult to navigate relationships, or if they just have unmet needs that they can get met better elsewhere, right? Because that's kind of normal to some degree. Therapists aren't supposed to be perfect themselves, so I don't know. It's weird. I hope it's not unethical. I hope they're okay. My response to her tweet, No BS Therapist, was like, oh, hell no. Because, like, fuck that. No way. Quick. Oh, there's just so many good ones. I think today's episode is just going to go long because there's just so much good stuff this week. So I have two posts back to back from this guy named Jeff Fine Thomas, and his handle is at JEFFFINETHOMAS, Jeff Fine Thomas. So the first one was 4 days ago. I hear complaints about unethical/inappropriate behavior from therapists more often these days than when I trained from more than 30 years ago. In parentheses, likely because the internet makes communication so easy. If you could fix the disciplinary process in our profession, what would you do? And I've sent this post to a couple of my friends. If you don't know, little inside baseball, for those of you who know nothing about psychiatry, psychology, etc., we have these boards. So like in California, I'm a psychologist, so we have the California Board of Psychology that monitors my license, my behavior on behalf of protecting the public. And so our ethics board, our consumer protection board is it has criteria for what's considered like illegal or unethical behavior and what's reportable. And thankfully in the state of California, the criteria are very rigid and very cut and dry. So it does weed out like unnecessary complaints or I don't like what my therapist said to me kind of stuff, because like, I don't know if you know this, everybody, but in psychiatry and psychology and professional therapy, having difficult conversations is normal. It's not all therapy sessions. It's not most therapy sessions, but sometimes doing individual therapy, group therapy, family therapy, we have to have uncomfortable conversations to help people grow, have a new perspective, or talk about something that's maybe not being talked about. And so uncomfortable, difficult conversations are part of good therapy. They're not the focus of good therapy, but they're part of it. So I'm not saying therapists should be bullies or something like that. Here's what I will say. If we were to fix all of our psychology boards or ethics boards or whatever it is, one thing you could do is you could make the ethics codes universal across all degree levels. That would be one thing. Another thing you could do is you could do what to their credit, the Board of Psychology in California, I believe, in my personal opinion, is a lot more cut and dried. And their criteria for what's considered a complaint is actually, in my opinion, again, my personal opinion, is very reasonable, right? And so if your criteria for what's considered an ethics complaint against a professional is very, again, cut and dried, like my therapist said something mean to me, is different than like my therapist tried to sleep with me, right? Generally speaking, those two things that I just, as like very obvious examples, who knows what actually was said in the my therapist said something mean to me example. But like if my therapist specifically tried to come on to me, that's just bad. There's just no two ways around it, right? So what I will say is it's absolutely the case that, your criteria should be cut and dried. Another thing that should be true is maybe the professions should get much better at screening out the people who shouldn't be in the profession. Like some people should never have made it into grad school. So a lot of grad programs need to up their criteria. I'm very grateful for the program that I work for as a professor because I think their admissions criteria are solid. I think the interview process is solid and we have such good students. I'm so proud to be part of my university and I'm so grateful that I get to be there. But not every school is like that. Not every higher education institution is like that. So that should change. Also, this is a field full of burnout. Psychiatrists, psychologists, LMFTs, LPCCs, many people are burnt out. I've been burnt out a few times in my career, and it's not good. It's not good. Sometimes burnout's more mild and manageable. Sometimes it's more serious and you need to go get therapy. Sometimes you definitely need to go on a vacation. Sometimes you need to take a break from practicing. Sometimes you need to stop practicing altogether. There's so many layers to it. But to really handle the ethics problems in this profession, other than like screening on the front end and getting rid of people who shouldn't be here, really, one of the bigger problems is there's so many people who are, like I said, getting their unmet needs met with their patients. That's not our job. Our job is to help them with their unmet needs and figure out a way to help them get their unmet needs met better in the world outside of here, not with us, right? We are not people's paid best friends. We are their mental health professionals trying to help them figure out these issues, develop skills and insights that will motivate them to go out into the real world and get their needs actually met effectively, consistently over time. In addition to stabilizing and managing their illnesses. So that's one thing. And then his second post, which was 3 days ago, was, I recently heard a local therapist call our profession the Wild West. What problems do you think exist in the profession? Well, like I just said, a little irreverence here and there. Like I just said, one of the biggest problems in the profession is so many people are burnt out. I think the second biggest problem is most people are not very scientifically minded. I think very few people actually understand the science of psychotherapy. Very few people spend a lot of time looking at the research. A third problem I think exists in the profession is very few professionals, psychiatrists, psychologists, and people of all degree levels are acutely aware of their countertransference issues and how it causes them to either be less than helpful or reactive or whatever it is in a way that's not good for the patient, right? So I believe many of the seriously unethical behaviors are due to just undiagnosed mental illness in the therapist or whatever, or burnout. But I believe on the more mild end of the problematic behavior of clinicians' perspective, it's purely just countertransference. They don't know about their childhood stuff, their dad stuff, their mom stuff, their sexuality stuff, their gender stuff, their masculinity stuff. I don't think they understand at all. I just don't. I don't think they understand at all. And so I think between just not being a good fit for the profession, countertransference, undiagnosed or undertreated mental health and substance use issues, I think those are the big drivers. Also, I think the financial incentives of the system are broken and flawed. I think that there's also a war, or like at least a lack of collaboration between psychology and psychiatry more broadly. I think the medical and the purely psychological side of it can do a much better job of collaborating. I think another issue is very few clinicians of every degree level are fully integrating bodily needs like sleep, exercise, and diet as a focus. I think for a lot of people these are secondary, but I don't think they're a focus for a lot of people. So I think that's a problem. So, yeah, I think, Jeff, just to say, those are the bigger problems, and I hope that we can all continue to have constructive conversations around those bigger problems. I would say, we could probably keep going, but I think I'm going to save some of those posts that I was going to discuss this week for next week's broadcast. It's been over an hour here. So thank you for the comments and for liking and sharing. Please, if you're new to the Psychology Checkup, which is my YouTube channel, or this particular podcast, which is the UnShrink Me podcast, please like, share, and subscribe. Please help get the word out. I'm here to help. My biggest passion is to help the profession heal. My second biggest passion is to help the consumers of mental health services, be it psychiatry or therapy or whatever, have a more healthy skepticism of the services they're being offered. So please like, share, and subscribe so people can hear at least my perspective, which is, I think, appropriately critical and sometimes satirical. And so, with every episode of UnShrink Me, I always end with a dad joke because it just seems to be my favorite type of humor. So, I once had a patient who had a condition called cynophobia. So cynophobia, if you don't know, I believe is an irrational phobia, an irrational fear of dogs. So this dude came in to ask me to do couples therapy with his girlfriend. Nice guy, perfectly nice guy. Girlfriend seemed perfectly nice as well. The main complaint was they're having a bunch of arguments because they're, figuring out if they want to stay together long term. And like one of the test scenarios is, can we handle a pet together? So she wanted to get a dog. And he did not want to have a dog because apparently he was suffering from what we call cynophobia. Terrible, cynophobia. Terrible, catastrophic fears and panic responses to seeing dogs. So this guy was literally in misery because he had these terrible panic responses to dogs. So they come in for their first session and they begin to explain all of their arguments and gripes and fears about relationship security because he doesn't want to have a dog and I don't know if he's going to be a good dad and all these things. And, to validate his experience, it seemed like he was really struggling with his fear a lot. He felt very ashamed that he had this cynophobia. And because, scope of practice as a psychologist, you're not supposed to, treat conditions that you have no knowledge or training or experience for. And so at the end of this first evaluation, because I'd done couples therapy, so maybe I could help them, but I've never worked with this condition. And it seemed like he needed some individual therapy, some exposure therapy for his cynophobia. And so at the end of the first session, they both looked at me and said, Dr. Lockwood, can you please help us? Because I really love him and I want this to work and I don't know what I'm doing. And he's like, yeah, I love her. And I don't know. I don't know if I can do this, but I'm just, I can't get over this cynophobia. And, they really were intently asking me to try to help them. And I said, I'm sorry, but it sounds like, I don't have any training for this particular condition. And it sounds like an individual therapy issue. So I'm sorry, but it's, you're barking up the wrong tree. So, thanks so much. Have a good day. Thank you for being here. Please like, share, and subscribe. And I will see you next Saturday, probably right around 3 p.m. Pacific Standard Time. Be well. Take care of yourself.